Hello, everybody. My name is Robert Riley, and I'm an interventional cardiologist in Seattle, Washington, in the United States. Also currently serving as the chair of the SCI Ischemic Council. And I've been asked to spend some time today talking about complications, sort of documenting, debriefing, and doing the right thing. These are my disclosures. So complications are hard to talk about. They're a bit of a nebulous topic. Don't think many of us get very good training on how to deal with them, and there's something that just sort of pops up. And I think to begin the conversation, it's really the understanding of the fact that mistakes or complications are really a part of practice, right? By its very definition, practice is that way. And this quote is really just fantastically amazing. It's summarizing the meat of what we're going to be talking about today, and the consequences of these mistakes and the possibility of them continuing to happen. And it's not if, it's just when they will happen. It kind of leads to an uncertainty about our own culpability, the medical and societal denial that these don't have to occur, right? Everybody thinks everything's supposed to be perfect. It's not, whether it's a hospital, societal, etc. And it really puts us quite in a lurch, right? Because we know that by definition, we're not perfect and things are going to occur, and yet we want to give patients the best we have. And so it really can be quite a difficult paradox for us to walk as physicians. And so when we think about, complications, so who suffers? Well, the patient, right? We've all been trained from the get-go to put the patient first, and that's right and good. But what we haven't been trained to do very well is to think about us, right? Because complications affect us. They affect those that work around us. They can spill into our families, and it affects the hospital or institution that you work in as well. There's a great article a couple of years ago, you can see the reference at the bottom, talking about the complication circle. First victim, patient, right? And then looking at the second victim, the person where the complication occurs, and then the third being the facility. Then doing some extrapolation on that second victim, or us, right, as physicians, all the different consequences, whether it's emotional, behavioral, psychological, and all of the things that go into that, and all of the consequences that can occur from that. Same article talked about the feelings that go along with these complications. We talked about depression, anxiety, disappointment, shame, sadness, guilt, anger, and I would guarantee anybody who's watching this who's a physician has felt these things after something hasn't gone well. And it doesn't matter whether you're an interventionalist or not, we've all had these things happen because we're imperfect people trying to treat people with disease, oftentimes usually that we didn't cause, but we're trying to help. And by nature, the imperfection comes through in these types of complications. So the real question is not, how do I prevent these things from happening? Because they will. The real question is, how can we look at these things and get better from them? So my good friend Sandra Kala up in Canada came up with a really good approach called PETALS. So when we have a complication, using this to sort of create a framework for us to do some analysis. So the first in PETALS is P, the predictability of the complication. So could I have foreseen this happening? If so, could I have done any steps differently to either mitigate it happening or deal with the consequences in a more efficient manner? The event prior that caused the complication. Complications usually aren't spontaneous, right? They're usually an effect of something else. So is there something that we could have seen or done differently in order to mitigate that? The treatment that you ended up doing. So did we do the right thing when we were supposed to do the right thing? So the timing of things, looking at the sequence of events and ensuring that there wasn't anything we could have done in terms of being more efficacious, in terms of efficiency, and the right therapy employed. Advice, so now that I put all this together, seeking someone to say, could I have avoided this? Could I have treated it better? Is there some way to avoid this in the future? So my lesson zone, are there things that we learn about ourselves, our environment that we work in, our administrators, our family, anything beyond just the technical aspects that we talked about earlier that we can sort of take to heart and move forward with, and then sharing and support in a safe peer review kind of way. And that's going to be multi-level. We'll talk a little bit about that, but having friends and colleagues that's safe to talk to, ideally a mentor, somebody that can help you through these kinds of things. Hopefully your hospital is a safe place to talk about that in peer review, and then figuring out if it's not, how you can move forward with that. Looking back in systemic, with a systems process as well, there's the 5 R's as well that Sandra has come up with. And that's, first one is recognizing this discomfort that you're feeling and accept that it's there, right? We don't have to be the silent warriors of 30 years ago. Bad things happen and it hurts, and we need to acknowledge that and be able to speak that into existence. Review kind of what you're feeling. What is that you're really feeling? What is the emotion? Name it, speak it. What is it doing to you? And then respond. Realize that we're not perfect. Giving each other grace, giving others grace, and being able to have some compassion for yourself and those around you. The redo. How do I wish that this had gone? And what can I change to potentially help things like this go the way that I want them to go in the future? And then the final R, the reframe and reach out. Again, sort of recontextualizing. It's not the fact that this shouldn't have happened. It did. What can I learn from it? How can I get better from it? And then how do I reach out, right? How do I help other people understand that these things do happen and we can learn from one another's mistakes, one another's practices in order to help patients moving forward? A little bit more about this second victim syndrome. I mean, a lot of the things we talked about, the PEDALs and the 5 Rs, are really about the list that we see here, and that's restoring personal integrity, right? We were all well trained. We all went in for good reasons to help people. And just because bad things happen don't mean that we haven't lived up to the ideals for which we started off on this journey of taking care of people. And it's really to be able to contextualize this and restore that personal integrity, and then making sure that we don't need some emotional first aid, right? So that we don't start going to places that we shouldn't in order to find support for this, whether it's substances, different other things like that. And again, really trying to reframe things so that we don't sink into some of these things that could be bad for us. Getting support from others, interventionists are very bad at this, right? We're asked to come in the middle of the night, save someone's life, and we kind of think it's by ourselves often, right? We don't often see the team around us. And, number one, we have to recognize that it's a team sport, right? And we need to take care of ourselves and those in our team. And as physicians, we are the leaders in there. And we really need to be more vulnerable and able to talk about this and get support from others. Having a mentor, so a coach, someone that's going to help you figure out, how do I get better, not just at my job and avoiding complications, but how do I progress emotionally as a human, personally? And that's going to involve mentorships, friends, spouses, family members. So that's kind of the emotional aspect. Let's talk about some practical stuff with complications, because there are practical aspects that are important, because we do live in a litigious world, right? And documentation is a big piece of that. If it wasn't written down, it didn't happen. Plain and simple. People's words don't account for as much as documentation. So the question is, what to document? What shouldn't you? And how much should you? Well, first thing is that you got to take a couple steps first, and then you can kind of move towards making sure that they're documented. So before you even get somebody on the table, right, you got to talk to them about all their test results. Why are we even thinking about this procedure? What are the alternatives? And ensuring that they know that, not just because that's good patient care, but you got to document it too, medical legally. Documenting the benefits and the risks, right? There are risk calculators out there, even for higher risk or chip procedures, being able to kind of give basic risks based on large studies that have been out there. If there's any specific risks to the patient, like renal insufficiency, somebody with chronic renal insufficiency, things like that, increased stroke risk, somebody with a stroke history, things like that, being able to put that down, not only talk to the patient about, but documenting it. Making sure you go over that consent form. It's really good practice to do it in the clinic when they're not under pressure, when they're not sort of being coerced, right? I showed up for the procedure, I'm getting my procedure, but to be able to go over that form, get them to sign it if that's what they want, and then documenting it in the chart at that time, scanning that consent at the time. And then EMR templates have been very helpful, I know, for me personally, in terms of documenting risk, doing education stuff for people, helping them understand their risk alternatives and all of that. Indications is huge, especially in a world where PCI is increasingly scrutinized, being able to say why this versus something else, and if this, what are the pros and cons? Has conservative therapy failed in terms of optimal medical therapy? Symptoms, lifestyle limiting being a huge aspect of often why we do PCI, so documenting that, and then the ever important appropriate use criteria. When we document, outside of just the upfront sort of consent of a patient, when complications happen, it's really important how you document them. First, be factual, right? Only things that happen, only things that can be verified. Keep your emotions out of it. There is no role in the medical chart for that. You only want to stay, and this is really important, not what I thought someone else was thinking, not what I heard this. It's just what you can verify, because You don't want to say anything that you're not going to have to repeat and be able to be verified in a court of law. And your staff can be really helpful with verifying timing of things. You never want to blame someone else in the chart, ever, 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 even if it's true. It's not the time and the place, it's not helpful, and it can lead to significant legal challenges down the road. And as we said, don't say anything that you don't want put in front of your face in a courtroom. You always want to save key images. That's really important when you're doing things. Obviously, if something happens, you always want to save those key images so that people can better understand what was going on, what went wrong, and what you did to address it. If the device malfunctioned, please save it, right? You're going to often send that back to the company anyway, but you got to save it. And then make sure you're documenting your clinical judgment response during those, timing, how everything unfolded. And again, staff can be really helpful. And at the end of the day, you really should be doing this, right? No fellows, trainees, it's not their role. It's your issue, and you got to take ownership. Dealing with patients and families is key. Always want to be transparent. You always want to be honest. You want to say exactly what happened, what didn't happen, and you want to document that. I spoke with the family, this, that, or the other. I can't tell you how many times I've heard, oh, and so doctor never showed up. They didn't tell me this, that, and the other. That seems to be the number one reason, if you look at literature, why people go to court, is that they think that the doctor didn't care or they didn't show up to speak with them. So that communication of both just doing it and then documenting it is super key. Again, avoid blame shifting, things like that. Risk management can often be helpful in these situations as well, so good social work.
Thank you very much. Again, for the sake of time, we are going to